The facial nerve is all about supplying those facial muscles and allowing for the whole range of facial expressions that they create. But don't just judge a nerve by its face, because that's not all it can do. The facial nerve is also involved in salivating, secreting tears, and it even plays a role in taste. On the other hand, the vestibulocochlear nerve is the cranial nerve that helps you hear your favorite song. So then you can use your facial nerve to smile when you hear it. And it also plays a role in balance, so you can dance along without tipping over. Understanding the anatomy of the facial and vestibulocochlear nerves is important, as damage to these nerves can cause significant impairments when it comes to facial expression, hearing and balance, among several other functions. Let's start with the general anatomy of the facial nerve. Remember that there are two facial nerves, one on each side, and each of them is primarily responsible for providing motor innervation to the muscles of facial expression. The facial nerve also innervates the stapedius muscle in the middle ear, gives parasympathetic innervation to the lacrimal glands, nasal glands, palatal mucosal, submandibular, and sublingual salivary glands, and also carries the special sensory information of taste from the anterior two-thirds of the tongue and the palate. It is also involved in the corneal reflex, also known as the blink reflex, which causes involuntary blinking when the cornea is stimulated to protect the eye from foreign bodies like sand. In this reflex, the trigeminal nerve is the sensory or afferent pathway, while the facial nerve serves as the motor or efferent pathway. Now, the clinical presentation of facial nerve damage is called facial nerve palsy. If the entire facial nerve is damaged, all of its functions are affected. Without motor innervation, facial muscles become weak or impaired. This means the affected individual will have trouble when trying to smile, frown, raise their eyebrows, puff their cheeks, or whistle. Paralysis of these muscles can also cause the face to look different on the affected side. For example, there can be loss of the characteristic nasolabial fold or less wrinkling in the forehead when compared to the unaffected side. Because the orbicularis oculi muscle is affected, the lower eyelid can become everted, and they can't close the affected eye. Because the sphincter and dilator muscles of the mouth are affected, the corner of the mouth droops. There is also decreased tear secretion, decreased salivation, and loss of taste due to loss of innervation to the lacrimal glands and submandibular glands. Since the stapedius muscle normally acts on the stapes to dampen down excessive vibrations, when it loses its innervation and becomes paralyzed, increased sensitivity to certain sound frequencies can result, which is called hyperacusis. Finally, if you stimulate the cornea by lightly touching it with a piece of cotton, you will notice that the corneal reflex is absent, meaning that there is no involuntary blinking. The facial nerve can be injured in many ways. If the fibers above the facial nucleus are damaged, it is referred to as an upper motor neuron lesion or central facial palsy. Common causes include stroke, trauma, multiple sclerosis, and brain tumors. Remember that the facial nucleus has a dorsal and a ventral part. The dorsal region controls the muscles of the upper face. It receives innervation from the upper motor neurons from both the right and left hemispheres of the brain, meaning it is under bilateral control. So, if upper motor neuron fibers from one side of the brain are damaged, they still receive innervation from the upper motor neuron in the other hemisphere. So the muscles of the upper face won't be affected with a unilateral upper motor neuron lesion of either facial nerve. On the other hand, the ventral part of the facial nucleus, which controls the muscles of the lower part of the face, only receives innervation from the upper motor neurons of the contralateral hemisphere. Therefore, an upper motor neuron lesion will result in contralateral dysfunction of the muscles of the lower face. This is because the upper motor neuron fibers decussate right before synapsing with the lower motor neuron, so symptoms of upper motor neuron lesions will appear on the contralateral side. A good way to remember this is to think of the phrase upper spares upper, meaning an upper motor neuron lesion will spare the muscles of the upper face and will only affect the muscles of the lower face on the contralateral side. A lower motor neuron lesion, or peripheral facial palsy, refers to any injury that affects the facial nerve from the facial nucleus up until it gives off its terminal branches. Things are a bit different now. There is no dual innervation here, and fibers travel through the lower motor neuron to the ipsilateral side. Also, information from both the dorsal and ventral parts of the nucleus are together at this point in the nerve. So, these lesions will affect all muscles of facial expression, both of the upper face and the lower face, on the same side as the lesion. Okay, that was a lot of information. Can you tell the difference between central and peripheral facial nerve palsy? Great. Now let's look into Bell palsy, which is the most common cause of peripheral facial palsy. The cause of this condition hasn't been established yet. but it is thought to be caused by the reactivation of the herpes simplex virus. In addition to unilateral facial paralysis, those with Bell palsy may also have hyperacusis, decreased tear production, and loss of taste to the anterior two-thirds of the tongue. Another cause of peripheral facial nerve palsy is Ramsay Hunt syndrome, which is a lower motor neuron palsy of the facial nerve, which is caused by the varicella-zoster virus, the same virus that causes chickenpox. Now, after someone has had chickenpox, the virus can remain dormant in the geniculate ganglion of the facial nerve. Later in life, the virus can reactivate and cause symptoms in the distribution of the facial nerve. Symptoms include painful blisters around the external ear canal and pinna, along with signs of facial nerve palsy. Sometimes, blisters can appear on the tongue as well. Parotid gland disorders, like tumors or inflammation, can also cause facial nerve palsy. Once again, let's go back to basic anatomy and figure out how this works. The motor component of the facial nerve enters the parotid gland, where it completes its journey by splitting into 5 terminal branches: the temporal nerve, the zygomatic nerve, the buccal nerve, the marginal mandibular nerve, and the cervical nerve. These branches are responsible for innervating the muscles of facial expression. Now, if the parotid gland becomes enlarged, it puts pressure on the facial nerve and causes facial nerve palsy. In this case, there's no hyperacusis or loss of taste, as the nerve testopedius and chorda tympani have already branched off from the facial nerve before it reaches the parotid gland. Other causes of peripheral facial palsy include trauma, especially to the temporal bone, otitis media, birth injuries, tumors, infections like mumps, mononucleosis, Lyme disease, and systemic conditions like sarcoidosis and diabetes mellitus. Medical procedures like mastoid surgery or parotid surgery can also result in injury to the nerve as well. Now, the facial nerve is most vulnerable in babies, and that's because the mastoid process is not yet fully developed. So in this case, the nerve can be damaged due to birth trauma, especially if forceps are used. Just like in adults, this type of injury to the nerve leads to an ipsilateral facial palsy. However, unlike injuries in adults, this one is more serious because one of the affected muscles, called the buccinator, is vital for suckling and therefore feeding. Okay, now let's switch gears and discuss some clinical conditions affecting the vestibulocochlear nerve. You know the drill, basic anatomy first. The facial nerve and the vestibulocochlear nerve both emerge between the pons and medulla near the cerebellopontine angle and travel through the internal acoustic meatus. Because of this close relation, some tumors can affect both nerves. Cerebellopontine angle tumors can damage both nerves right as they emerge from the brainstem. Symptoms include facial palsy, sensory neural hearing loss, vertigo, and cerebellar symptoms like poor coordination, unsteady gait, and slurred speech. One of the most common types of tumors found at the cerebellopontine angle are acoustic neuromas, also known as vestibular schwannomas. This is a growth that arises from Schwann cells of the vestibular portion of the vestibulocochlear nerve within the internal acoustic meatus, and often expands proximally to enter into the cerebellopontine angle where the nerves originate. Remember that both the facial nerve and the vestibulocochlear nerve travel through the internal acoustic meatus together. Patients with this tumor primarily present with hearing loss and tinnitus because of cochlear nerve involvement, but facial palsy as well as vestibular symptoms are also common. Alright, as a quick recap, symptoms of facial nerve palsy usually affect one side of the face. They include facial muscle weakness, inability to frown, smile, or whistle, lower eyelid eversion, mouth corner droop, decreased tear secretion and salivation, loss of taste, and hyperacusis. Upper motor neuron lesions, also known as central facial palsy, are caused by lesions above the facial nucleus, like stroke, trauma, multiple sclerosis, and brain tumors. Muscles of the lower face on the contralateral side are affected, but upper face muscles like those in the forehead are spared. Lower motor neuron lesions, also known as peripheral facial palsy, can happen at the facial nucleus or along the nerve itself. It can be caused by Bell palsy, trauma, infections like Ramsay Hunt syndrome, certain surgical procedures, sarcoidosis,